Right, shall we start? So good morning, afternoon, evening, everyone. Welcome to today's seminar. The webinar is brought to you by the Infectious Disease Data Observatory, IDO, Mahidol Oxford Research Unit in Bangkok, where I am, the Oxford University Clinical Research Unit from the Hospital for Tropical Diseases in Ho Chi Minh City, with support from the Global Health Network. So our topic today is radical cure of vivax malaria. Can we do better? My name's Nick White from Moru in Bangkok, and I'm delighted to be joined today by my co-chair, Dr. Chau from OCRU in Ho Chi Minh City. And our speakers today are Dr. Rob Commons, Dr. Alison Roth, and Dr. James Watson. So first, briefly, housekeeping. This session is recorded. Recording will be shared on the IDO website, and we'll share the link when it goes live. To interact with the panel, please use the chat to introduce yourself and post your questions in the Q&A at the bottom of the screen. And you can find, so it's in the toolbar at the bottom there. If you've got any technical issues, just let us know in the chat and the technical team will assist you. We've got dedicated time allocated for the Q&A after the talks, and we'll try and get through as many questions as possible, but apologies in advance if we don't get to your question. So let's begin the program for today. And I'd like to now introduce and welcome Dr. Rob Commons from the Menzies School of Health Research, who will talk about aminoglycerines and hemolytic irony. Over to you, Rob.
Thanks very much, Nick. It's fantastic to be talking today about aminoglycerine dosing, and very exciting to have everyone on board. So thank you for joining. So, as everyone online is probably well aware, that effective treatment of vivax malaria requires treatment of both the blood stage to kill off the blood stage that makes our patients sick, but also treatment of the hypnozoites that hide in the liver and relapse, leading to infections later on down the track. And this really leaves us with a problem, because to do this successfully and to kill off these hypnozoites, we have just one class of drug. And within that class, two drugs, one that's very old and one that's quite new. While they both prevent relapses, they also both come with another problem, and that is hemolysis. And it's really a matter of balancing these two things and trying to work out where we should be with these two things. So while anti-relapse efficacy is correlated with the total dose of Primaquine, the risk of hemolysis in comparison is primarily correlated with the daily or cumulative dose. Which leads us to the question, what dose and potentially what duration of treatment we should be doing, especially when we're talking about Primaquine, and that's what this talk will be focused on. As a reminder for everyone, I've put a little table here about the different doses of Primaquine that are used, recommended, but also used in research. And as you can see, I've listed them by their total dose and also by their daily dose. So you can see that there's two total doses, the low dose 3.5 milligrams per kilogram and the high 7 milligrams per kilogram, and three daily doses, so 0.25 low dose, 0.5 milligrams per kilogram per day intermediate dose, and 1 milligram per kilogram per day high dose. But what's the evidence for using these? Well, initial studies varied, but one of the initial studies on the Chesson strain suggested that actually none of these doses, but one in between, 5.25 milligrams per kilogram total dose over 14 days, probably had greater efficacy than 3.5 milligrams per kilogram. But there was remaining concerns about safety. And there was substantial US military experience with the 3.5 milligram per kilogram dose over 14 days and reasonable safety signals, although that can be debated. Currently, the WHO recommends 3.5 milligrams per kilogram per day or 7 milligrams per kilogram per day for different vivax endemic regions. The 7 milligram per kilogram is recommended for Southeast Asia and Oceania, similar to the red circle on the map there, with 3.5 milligrams per kilogram recommended for all other regions as a total dose. And that's over 14 days. Recently, they've also added the recommendation for a low dose, 3.5 milligrams per kilogram over 7 days. Unfortunately, the vast bulk of practice is that people use 3.5 milligrams per kilogram over 14 days because there's concerns about safety. So really this leads to the question, well, is it worth pushing the dose? Is it worth going to 7? And unfortunately, there's a severe lack of direct evidence. Cochrane review published a few years ago now found only 2 RCTs that were included in the review that compared the 3.5 and the 7 milligram per kilogram per day doses. And that's really where this some of the studies that we have undertaken come in. So rather than design a clinical trial across all endemic regions with thousands of participants costing tens of millions of dollars probably, or potentially more, we approach this question from an alternative perspective. We know Primaquine's been available for 70 odd years. And so in collaboration with Nguyen, we undertook a systematic review. We collated individual patient data, so the original patient data, and undertook a meta-analysis to explore this in more detail. We identified that there were 96 studies that were eligible for this. Around a third of these studies, just over, were able to include with 8,500 patients from 19 countries. And you can see the breakdown of the different Primaquine treatment categories on that figure on the right. So part of the question, obviously, is we looked at the efficacy of Primaquine dose. And this included around 6,800 patients. And this figure here plots the adjusted results from a Cox regression model, which was adjusted for age, sex, baseline parasitemia, and study site. It shows time over days versus risk of recurrence. And you can see quite clearly there's a benefit from giving Primaquine. For example, for the high dose Primaquine with the red line compared to the black line, no Primaquine, the adjusted hazard ratio is 0.1. And this means that for the number needed of patients needed to treat to prevent just one recurrence, you only need to treat just over 1 patient. Probably most importantly though is what's the difference between low dose Primaquine and high dose Primaquine? Is there a benefit with high dose? And we could see that there was a benefit. The adjusted hazard ratio with high dose Primaquine compared to low was 0.45, and the number of patients needed to treat to prevent 1 recurrence was 10. When we look at subgroups of patients by age or by their geographic locations, the results were fairly similar. So we were expecting to see that high dose Primaquine would be better in those with high relapse periodicity. So this is in Southeast Asia and Oceania. But what was slightly surprising was that it was also better in other regions. So in other parts of Asia, Horn of Africa, and the Americas. And this is the regions of low relapse periodicity. There were benefits in all age groups, although it's worth noting that low total dose Primaquine was probably less effective in patients less than 5 years of age. So should we restrict ourselves to these categorical doses that have been used historically? Potentially not. And we looked at this from a different perspective. We looked at this looking at Primaquine dose as continuous variable. And this figure shows it compared to the hazard ratio, comparative hazard ratios with a reference of a Primaquine dose of 2 milligrams per kilogram total dose. And as you can see, basically as the total Primaquine dose increases to the right, the hazard ratio falls until you get to around 6 or 7 milligrams per kilogram, where it starts to flatten off. So it probably is a reasonable option to use a 7 milligram per kilogram total dose to get the maximal effect. I guess the elephant in the room and the cause for concern for all the clinicians and policymakers and researchers who are on tonight is hemolysis. And if we look at those who have normal G6PD activity, and by that I mean patients with greater than 30% G6PD activity, and compare patients receiving Primaquine versus those not receiving Primaquine, we can see a similar pattern. We see patients fall to an nadir hemoglobin around day 2-3 before rising. Importantly, in a population level, there's no difference between the hemoglobin levels in patients receiving Primaquine and those without. But by day 42, there's actually a benefit with a higher hemoglobin level in patients receiving Primaquine, because they're preventing the relapses that we know put a downward pressure on your hemoglobin and cause anemia. This was a small study we did a couple of years ago, or a smaller study, but we're now undertaking a larger study focusing more on Primaquine dose, and this has been led by Meg Rajasika. This forest plot on the right shows the dose, shows the adjusted values for the absolute change in hemoglobin at day 2-3 compared to day 0. And what you can see is for all 4 treatment categories, including those with no Primaquine, there's a very similar effect at a population level. So population level is one thing, but the biggest cause for concern are the outliers. What happens to the people that have a severe event? And one option for defining a severe event is someone who has a big fall. So someone who falls greater than 25% to something that's clinically relevant. And we're aware that falling to less than 7 grams per deciliter of hemoglobin is a potential reason for a blood transfusion. So I've pulled out these people here and added them in by treatment category. You can see that there was 1 patient who received no Primaquine that had this event. There were 4 and 6 patients respectively in the intermediate and high dose groups that also had this event. Let's narrow down further, because the group of people that we're potentially most concerned about with hemolysis are those with G6PD activity of 30 to 70%. And this includes a large number of female patients who are heterozygous for G6PD deficiency. This figure, again adjusted for a number of confounders, shows G6PD activity versus the day 2-3 hemoglobin. And what's important is that you can see that there is a relationship or correlation between G6PD activity and day 2-3 hemoglobin in that 30 to 70% range. If we look at this in more detail, so narrow down on the 30% to 70% G6PD activity, this is a plot of all the unadjusted values, all the actual patient values. The solid circles are male patients, the open circles are female patients. It's quite a busy figure, but we use this to be able to look at safety measures in more detail. And you can see here the same safety measure we mentioned before, listed by the same categories, but now restricted to patients who had 30 to 70% of G6PD activity. There are low numbers, but you can see that there were no patients with receiving no Primaquine, receiving low daily dose Primaquine, or intermediate daily dose Primaquine that had this event occur. There were 2 patients receiving high daily dose Primaquine, so that's 1 milligram per kilogram per day, both who were female who had this event occur. Both were from the same study. But again, it's worth noting that all of these groups are quite small. So what can we conclude? What can we summarize? It seems fairly clear cut that a high total dose Primaquine is more effective than low total dose Primaquine in many regions. And it's probably worth noting that this is standard treatment in many countries, including countries such as the United States, the United Kingdom and Australia, where routine G6PD testing is available and performed over at a 30% level. And we can say that increasing the total dose of Primaquine to 7 milligrams per kilogram for 3.5 reduces the risk of recurrence by around 55%. But there are regional and individual variations. And one of the important things is that some of these variations potentially are the reason why there is a benefit of high dose Primaquine in low relapse periodicity countries, outside of what we might have traditionally thought. So it may be that this high dose is overcoming some of the risks or some of the treatment and factors impacting this, such as poor adherence or CYP2D6 genotypes. In terms of hemolysis, there was no increased risk of hemolysis with Primaquine in patients with greater than 30% G6PD activity at a population level. But what about those severe events? What about those outliers? Well, from these results did not appear to be an increased risk of severe events in patients with 30 to 70% activity who were treated with 0.25 or 0.5 milligrams per kilogram per day. But there was a signal of increased hemolysis in female patients at 1 milligram per kilogram per day. Although it's worth noting that these data were sparse. We are getting some additional data on these groups of patients coming through in the next few months. So hopefully we'll be able to answer this question in more detail. Finally, I'd like to thank everyone, many of whom are on this call, who have contributed this data and these studies, in particular, the Meg Rajasika, Rick Price, Julie Simpson, and Peter Adler, who've helped me with this work.
Thanks a lot, Rob. To all of those of you online, keep posting your questions in the Q&A. We will have that session after the 3 speakers. So pleasure to now introduce Alison Roth of the Walter Reed Army Institute of Research, who's going to tell us about her laboratory studies. Over to you, Alison.
Great, thank you for the introduction. It's a great pleasure to be here today, and I want to thank all of those who have joined live. Quick disclaimer. So as Rob mentioned, Plasmodium vivax has a quiescent dormant form that's called the hypnozoite. And when reactivated, this causes relapse and leads to another active infection. There's very limited anti-hypnozoite drugs. As Rob mentioned, only Primaquine and Tafenoquine of the acetaminophen class are the FDA-approved drugs that are active against hypnozoites. There's also very limited knowledge of 8AQ mechanism of action in the liver, and that will be the topic of this talk. So there, in the malaria field, there are many relapsing malaria liver models. These range from cell lines to all the way up to in humans, and all these models have a pros and cons that are associated with them and have a different physiological relevance. These range from infection rates, cost, and throughput. All these models require sourcing of Plasmodium infected mosquitoes, which is critical to performing the assays. Plasmodium vivax requires patient blood from endemic countries, which can be very difficult to source and making these assays very limited. P-cytomolgi requires non-human primates. This, however, can be a controlled study, allowing for easier use and access. So at RARE, we have set up the P-cytomolgi hypnozoite assay, where we receive mosquito shipments on a bi-monthly basis from our partner institute, AFRIMS, located in Bangkok, Thailand. We run this in a 384-well plate format, and every aspect of the assay has been fully automated to liquid handling. This allows us to run thousands of compounds at a time. The assay is also able to be performed in 2 different treatment modes, looking at prophylactic and radical cure active drugs. The assay is also a phenotypic readout, so we use a high content imager to look at specific stains regarding the parasite and the hepatocyte population. We then use an in-house analysis that was built to analyze our data. So using our model, we've evaluated Tafenoquine. Shown here on the left are the curves in prophylactic and radical cure mode. Tafenoquine is highly potent in prophylactic mode with nanomolar activity. In radical cure mode, we see low micromolar activity and clearance of both hypnozoites and schizons. We've also used this model to then evaluate Tafenoquine analogs in order to find compounds that are improved in efficacy and reduce in toxicity. Shown here in these 2 graphs, we have the test compounds shown in blue, and Tafenoquine is shown in green, where a non-8AQ control compound is shown in purple. We can also use this assay to understand drug-drug interactions in other acetaminophen treatment regimes. This is important as geographical chloroquine resistance has made it necessary to replace chloroquine with a different partner drug. Historically, Tafenoquine has been partnered with chloroquine. However, this has been shown recently when replaced in the inspector trial with DHA piperacin, that this is important to evaluate other partner drugs. In this study, it was performed in 2019 in Papua New Guinea. They found that Tafenoquine partnered with DHA piperacin showed poor efficacy. This led to us joining a collaboration with MMV, GSK, UGA, and the Institute of Pasteur in order to use our respective models in order to decipher and investigate the failure of Tafenoquine partnered with DHA piperacin. So shown here are our results. In our model, we found that Primaquine or Tafenoquine partnered with chloroquine showed synergy. This is shown here in green. There's about a 10-fold increase in efficacy when Tafenoquine is partnered with chloroquine and similarly with Primaquine. This has also been previously shown in non-human primate relapsing models, as well as in previous clinical trials. We also found that there was a reduced efficacy of acetaminophen when combined with DHA and piperacin, and this is replicating what was shown in the inspector trial. We also found that chloroquine and piperacin did show some synergy with Primaquine and Tafenoquine. And ultimately, it's apparent, and what we've concluded is that DHA is antagonist with other aminoglycanins. We can also use this model to investigate the hypnozoite transcriptome. Shown here as an RNA-seq study, which we used P. cynomolgus infected cultures and compared the transcriptome data to published vivax data, where we found a very high correlation, allowing us to use this as a mechanism to look into different hypnozoite biology. So we then wanted to elucidate the Tafenoquine mechanism of action. So we performed different drug combination experiments. We used a PI4K inhibitor, which is a chizant acting drug only, to clear the chizants from the hepatocyte culture, leaving only hypnozoites. We then did different doses of Tafenoquine and looked at both infected and uninfected hepatocytes. The TSNE analysis showed the ability to distinguish between samples in a concentration dose dependent manner, which allowed us to see a measurable mechanistic response. When we look closer at the host hepatocyte and the differentially expressed genes, we see that Tafenoquine exposed hepatocytes show upregulation of various pathways. These include autophagy, mTOR signaling pathway, mitophagy, the lysosome, and other immune response pathways. Of high interest for us, we also looked closer at the abundance of highly expressed genes. And what we found was there's an increased transcript abundance of P450, CYP3A4, and CYP1A1, which leads to the hypothesis that both of these are required for the metabolism of Tafenoquine. When we look closer at the clustering of hypnozoite-specific genes, we saw a decreased transcript abundance in genes involved in glycolysis and the redox pathways. Downregulation of the parasite's redox pathway could reduce the ability to manage oxidative stress, which would be due to the redox cycling of Tafenoquine parent to the active metabolite. So in summary, the in vitro P. cynomolgus model successfully serves as a surrogate to Plasmodium vivax and is effective for evaluating aminoglycanins with or without partner drugs. We also observed and replicated synergy with chloroquine plus 8-AQs in vitro. And we also observed replicated reduced efficacy of aminoglycanins plus DHA and piperacin. And we were able to gain further insight into the transcriptome of hepatocytes and hypnozoites treated with Tafenoquine.
Thanks a lot, Alison. That's great. Keep asking your questions, everyone. We'll come back to each of the speakers after the final presentation, which is going to be given by James Watson of OCRU in Vietnam. He's going to talk about his work reassessing Tafenoquine pharmacometrics. Over to you, James.
Thank you, Nick, and thank you to everyone who's joined today. So I'm going to talk briefly about Tafenoquine and the pharmacometrics of Tafenoquine and trying to optimize the Tafenoquine dose. So currently, Tafenoquine in adults is recommended at a 300 milligram dose. There's also a pediatric dose from 2 years and older. And to get Tafenoquine, you need to have more than 70% G6PD enzyme activity using a quantitative point of care test. And as mentioned by Alison, this is now recommended to be given with chloroquine only. So 300 milligrams, that's 2 tablets in the current formulation, which are 150 each. And then across the vivax endemic world, really, from my understanding, only patients in Brazil are currently getting Tafenoquine, but hopefully this will expand. Now, the question we had is whether or not 300 milligrams is in fact the right dose. And as mentioned by Alison, there was this trial in Indonesian soldiers, the Inspector trial, which showed quite poor efficacy of Tafenoquine when given with DHA proparaquine. And there clearly are some drug-drug interactions which are possibly important, but another important feature is actually the dose, and underdosing could possibly explain some of these results. So very briefly, to have a kind of, our sort of causal model, as it were, that's guiding this analysis. Tafenoquine's most likely a prodrug, so the parent compound isn't doing much. It needs to be metabolized in the liver, and then these active metabolites are driving the key clinical outcomes. So that's the hemolysis, so oxidant hemolysis of older red cells, especially in G6PD deficiency, and then killing hypnozoites, and then also production of methemoglobin. And so, this is these are all kind of correlated with each other, these outcomes. Now, in our work, we've looked at two key questions. So first of all, the relationship between the dose, so that's a body weight adjusted dose in milligrams per kilogram, and whether or not you get a recurrence, say within 4 or 6 months. And also, as Rob mentioned, and this talk is really very sort of parallel to Rob's talk, is the relationship between that dose and acute hemolysis. And this here is going to be restricted to patients who have more than 70% G6PD enzyme activity, because that's the data we have, the clinical trials, that was the key inclusion criteria. And so we've done an individual patient data meta-analysis. This includes all the pre-registration trials done by GSK, and the objective is to try and determine an optimal Tafenoquine dose. So very briefly, there are 4 trials that we've had access to. 3 of these are in vivax patients, so detective phase 2 and 3, and then the GATHER trial, and then 1 phase 1 trial in healthy volunteers. And looking at the vivax patients, in those who were followed up for more than 1 month, we've got data in over 1,000 patients. Over 600 of those got Tafenoquine. Most of them got 300 milligrams, but there are also some who got higher and lower doses. And about 250 got Primaquine, and the rest got no ataminoquinolone treatment. And we've also got rich PK data and also quite rich methemoglobin data. Now, if you just look at, very simply, the time to first recurrence in this pooled data set, as in Rob's data on Primaquine, there's a very, very clear dose effect. So the higher the dose of Tafenoquine you give, the less likely you are to have a recurrence by 6 months. And 5 milligrams per kilogram, so that's a 300 milligram dose in a 60 kilo adult. That's very approximately equal to the low dose Primaquine regimen that was used as a comparator in these studies. So that's 3.5 milligrams per kilogram given over 2 weeks. If we put all these data into one sort of dose response model, so something known as an Emax model, so this assumes a sigmoid relationship between the dose and whether or not the effect on reducing recurrence, then again, you get this very, very clear dose response. And this is using data from over 1,000 patients, and it's extremely clear that weight is a primary determinant of efficacy. And then the 5 milligram per kilogram dose is approximately equal to low dose Primaquine. And if you look at this, say, in a logistic regression model, you get very similar odds ratios for equal percentage increases in both the Primaquine and the Tafenoquine dose. So they really are quite, very similar to each other. And then if you turn this round into a, saying, well, what's the effect relative to the biggest dose I could ever give? So in these trials, the largest dose was approximately 15 milligrams per kilogram. No one got higher dose than that. So if you say, well, 15 milligrams per kilogram gives me my maximum dose, 0 gives me, 0 gives me no effect. 15 gives me 100% of the obtainable effect. And then what's the relative effect in between those doses? And under this, you get that 5 milligrams per kilogram is approximately 70% of the maximal obtainable effect. But the key point here, and this is really important, is that it's on this very steep part of the dose response curve. So, the mean weight in these patients was about 60 kilos. So they're on average getting 5 milligrams per kilogram, but small deviations in weight from that ends up in small deviations in milligram per kilogram dose, and actually quite large deviations in efficacy. And using this distribution of patient weights from these trials, we estimate that the 300 milligram dose gives you about 15 to 16% recurrence by 4 months. If you increase that by 50%, so that's just one extra tablet, then that would reduce it down to, say, 7%. So that's more than half. And put in a different way, for every 11 patients that you gave that one extra tablet, so that's 450 instead of 300, you would avert 1 recurrence. So it's quite a good number needed to treat. Now, the flip side of this is obviously hemolysis. Now, we've obviously the data we have are in patients who have a G6PD enzyme activity greater than 70%. And in these patients, you do see a slight relationship between the tafenoquine dose and the nadir hemoglobin, but the effect is very, very small. So for every milligram per kilogram increase in tafenoquine, you get a reduction of about 0.02 grams per deciliter. So for a 300 milligram dose, you might expect a 0.1 gram per deciliter reduction. And for a 450, that's 0.15. So that's less really than 1% reduction in hemoglobin, which is absolutely tiny. Now, this is when you're using one of these quantitative point of care tests. The effect of these doses in fully deficient patients, let's say less than 30% activity, is basically unknown because we have no data. So coming to the key question, which is what is the optimal dose? And optimality here is defined as this trade-off between the risk of hemolysis versus the benefit of curing patients from, curing them from their relapsing infection. So imagine if you were going to compare, say, the 300 milligram dose versus, say, the 450 milligram dose in the context of using a quantitative point of care test. You might imagine, well, suppose you have 1,000 symptomatic patients who come to a clinic, and G6PD deficiency is about 10% allele frequency. So maybe 85, 88% of those patients could be eligible for tafenoquine treatment. And if you give them a 300 milligram dose, you might avert about 309 recurrences. If you increase that to 450, you're going to increase the number of recurrences averted by about 70. And then on the harm side, this is very, this is almost pure speculation because we don't really know. This harm is only going to be in patients who are inappropriately prescribed tafenoquine. So, in any real world use of these point of care tests, there will be, some mistakes made, and occasionally you will get a fully deficient patient who gets prescribed this drug. And so you might expect, say, 1 hemolytic event per 1,000 patients, and maybe if you increase the dose, that might go to 2 per 1,000. And I'm not saying what the optimal dose is, but defining the optimal dose is this trade-off between this very uncertain risk in a very small subgroup of patients versus a very clear benefit in the very large majority of patients. And I think the key takeaway here is we now need some double-blind randomized trials which are comparing higher dose tafenoquine to the standard, to the current dose. And this will allow us to better assess the risks and the benefits. So I'd like to thank co-authors on this paper, especially Rob, who did a lot of this work with. And if you're interested, please read our eLife paper. And I'd also like to thank GSK for providing access to all their data. Thank you very much.
Thanks, James. So now we start with the Q&A session, and I'll read This is for you, Rob, from Mohammed Farouk. Is there any recommendation, consideration of weekly doses without testing for all those settings where the testing is operationally not feasible, either for qualitative or quantitative testing of G6PD status? More specifically, before starting the transmission season as RDA, 4 rounds of chloroquine and weekly Primaquine. But I think the first part of the question is of general relevance. Over to you, Rob.
Thanks, Nick, and thanks, Mohammed. So absolutely. So in patients who are G6PD deficient, then WHO recommends, and many countries do, give the 8-weekly course of Primaquine at 0.75 milligrams at once a week, every week for 8 weeks. And it depends really on the individual setting. Some settings where G6PD deficiency is known to be extremely low. I know there are countries that give daily Primaquine dose regimens without testing, but in general, we would recommend not doing that. And if you can't test, then it may be safer to not do that and to actually give the 8-weekly dose. But that's really a trade-off based on the types of G6PD genotypes, how severe those variants are in your setting, and what's known about the rates of G6PD deficiency in your setting, because it could potentially lead to severe hemolysis. I don't know if anyone else wants to add anything further to that.
Thanks, Rob. Dr. Chau?
So second, I have a question from Michael White for both of you, Rob and James. From a patient litigant perspective, it's clear higher dose prevents more relapses, impressive hazard ratios. But from a population and national malaria control program perspective, what reduction in transmission, for example, the prevalence of malaria, would you expect to see when introducing low or high dose into routine case measurement? James, you can come first.
Sure. So, well, this is speculation because it's, I guess this is more of a guess than anything else. But we know that relapses contribute most infections. So maybe 4 out of 5 infections are going to be caused by relapse. It probably caused quite a lot of long-term, chronic asymptomatic infections, which are contributing to transmission. So it could possibly have quite a big effect on transmission to give a higher dose. I mean, how to quantify that is difficult, though.
Yeah, I think further. Sorry.
Do you have any comment?
Yeah, I guess just further to that, we know that unfortunately not everyone's able to get receive Primaquine. So there are a proportion of people that are unable to see Primaquine or Tafenoquine. So that's going to reduce the numbers. But I guess further to what James was saying, that if you are seeing that 8 out of 10 cases of malaria, of vivax malaria, are due to relapses, then we would expect, if you gave low dose Primaquine, maybe there would be that would reduce, say, 6 of those 8 cases. And if you gave high dose, that might reduce it 7 of those 8 cases, something along those lines. And you could sort of back of the envelope calculate out what that might look like from a perspective. But I'm guessing that Michael White might actually have an opinion on this as well.
Thanks, Rob and James.
Thanks. Okay, I've got one for Alison now from Dennis Shanks. Does your gene expression data indicate that Tafenoquine metabolism, which you imply is CYP1A1 or 3A4, is distinctly different from Primaquine metabolism, at least the active metabolites, which is 2D6? Alison.
Mm-hmm. Yep, thanks for the question. So unfortunately, we haven't run the transcriptomics studies on Primaquine. However, we do hypothesize that there is going to be a difference. We did not see an increased transcript abundance of CYP2D6 on the Tafenoquine treated cultures, only CYP3A4 and CYP1A1. we are hoping to run and repeat these studies using Primaquine.
We have another question for Alison. Great presentation. So looks convincing drug-drug interaction between DHA and Tafenoquine, and similar magnitude the drug-drug interaction between DHA and Primaquine. So did you do similar transcriptomic studies for Primaquine liver stages? And are the mechanisms of this drug-drug interaction similar?
Yeah, so unfortunately, we haven't repeated the studies with Primaquine. That is on the to-do list. But as I mentioned earlier, we are thinking that this will be different between Primaquine and Tafenoquine, and that CYP2D6 is going to be more specific for the metabolism of Primaquine versus Tafenoquine.
Thanks, Alison.
Thanks.
Okay, I've got another one. Well, I've got two from Iodia, so I'm going to ask the first one, which is for Rob. What's your suggestion for the optimum dose of Primaquine in children? Put you on the spot.
Thanks, Iodia. So I think the key takeaway from the forest plot, which was sort of just I focused on very briefly, was that in children who are less than 5 years of age, the relative benefit of high dose total Primaquine compared to low dose total Primaquine was greater. So although the absolute benefit or the absolute reduction with high dose was very similar to other age groups, you know, children 5 to 15 years and adults or people older than 15 years, the low dose treatment regimen in children less than 5 years was less effective. So this would suggest that this, if you were going to change the dose in any group, this would be the group that would potentially have the greatest benefit from it. And sort of carrying on from that, I suppose the optimal dose from what we've identified would suggest that sort of a 7 milligram per kilogram total dose would be what we're looking at.
Thanks, Rob.
I have questions from Rick Price. Rick Price, do you want to open up your microphone and ask your question? Otherwise, I can read your question online. So the questions of Rick Price is, we know that high dose of Primaquine combination with ACT does work well in vivo. So increasing dose also rapidly overcomes poor metabolism with CYP2D6 mutations. So why isn't the solution the same for Tafenoquine? Increase the dose and get higher on the dose response curve. James, can you answer this question?
Yes, so there's been some nice studies. Well, one nice study in particular at SMRU on the Thai-Myanmar border, where they gave high dose Primaquine with DHA Primaquine, and they got exactly the same recurrence rates as high dose Primaquine with chloroquine. So clinically, I think that's that's the case, and that was a large study. So I imagine the same would be true with Tafenoquine, but I'll let Alison have her say as well.
Thanks, James.
So that is also our belief that if you increase the dose of Tafenoquine when partnered with DHA Primaquine, that is a possibility that you can overcome the antagonism. We are conducting in-human primate studies as well, where we're hoping to explore that as a possibility. But so far, we're just not sure.
Thanks. I've got a question here for James, difficult one, James, from Kevin, characteristically. Thank you, Kevin Baird. Thank you for mentioning the accidental ataminoquinolone dosing of G6PD deficient patients as a reality. Should we wait to see what happens at 300 milligrams of Tafenoquine, because we will get that information? in hemi and homozygotes before advocating the 450 dose? What might be a harm threshold for acceptable versus unacceptable hemolytic anemia?
Well, so I think the second part of that question is unanswered, as I'm not a clinician, so I can't really answer that, but my understanding is people haven't really agreed what a good, a simple definition of this is. But so, yeah, I mean, I also think we do have some data of Primaquine given to hemizygote deficient males. And so we might be able to use that to then extrapolate what would happen with Tafenoquine given to hemizygote deficient males. But yeah, that is a difficult question.
So next we have a question from Iodia for Alison. You mentioned that Tafenoquine doesn't work well together with DB. Is there any way to improve this, or Primaquine is preferable to combine with DB?
Sure. So we saw that the reintroduction of, in the in vitro assay, the reintroduction of chloroquine with Tafenoquine DHA did improve the efficacy. However, clinically, we don't know if that's going to also have an improvement on the combination. So we are alternatively exploring other combinations of ACTs with Tafenoquine in vitro. And also, as I mentioned earlier, potentially increasing the dose of Tafenoquine when partnered with ACT could overcome this liability. However, you could be facing potential increased hemolysis. So it might be a balance game.
Thanks, Alison.
Alison, I've got one for you. The antagonism with the DHA. I mean, DHA is very rapidly eliminated in a half-life of an hour, and Tafenoquine hangs around for weeks. Do you think that brief exposure, or how do you explain that brief exposure would have such a profound effect? Over. Yep,
great question. So that's something that we've been trying to answer within that group, that consortium with MMV, GSK, and UGA. Right now, we're still trying to figure out exactly how DHA is having such a antagonistic effect on Tafenoquine. The thought is that somehow DHA could be retained in the liver to a degree where maybe it's being housed and still actively interfering with Tafenoquine. The other possibility that we're trying to explore is if we can do dosing of DHA piperacin first, wait till that's removed, and then do a dose of Tafenoquine and see if that returns the efficacy of Tafenoquine.
Thanks.
So another question to James, very interesting question and practical. James, another red talk. I'm not sure a single dose of Tafenoquine or Primaquine in all adults is appropriate. 300 milligram in 35 kilogram adult women, approximately 8.6 milligram per kilogram, is probably effective. But 600 milligram needed in an 80 kilogram male, approximately 7.5 milligram per kilogram. A single dose of 450 milligram would overdose a 35 kilogram female and underdose a 120 kilogram male. So why don't we use simple dose bending in adults, small, medium, and large? What is your opinion, Jeff?
So I'm getting all the questions that I can't really answer. I mean, clearly, if you can do weight-based dosing, then that makes the most sense. But then talking to people, a lot of people seem to think that that's impractical for, in malaria endemic areas, in, low resource settings. There are no other anti-malarial drugs that are dosed by weight in adults. So, this would be the only one. But yes, it clearly makes sense. And it reduces these outliers. So these, very heavy patients who are getting very low doses, and then the very light patients who are getting very high doses. So if it's practical, then that is definitely a much, much better approach.
Thanks, Chen, for your answer.
May I ask another one? I'm going to take chairman's privilege and ask Alison another one. So I noticed that the IC50s for Tafenoquine for the pre-erythrocytic prophylactic activity were way, way lower than for the hypnozoitocidal activity. I think it's about 15-fold lower. Do you think that means that actually Primaquine would have, or sorry, Tafenoquine would have pre-erythrocytic activity at much lower doses than are currently being used? And would that extrapolate also to Primaquine? How do you explain that very large difference? Over.
Yep, sure. Great question. So when we're running the prophylactic mode in the assay, we're doing a drug treatment starting on day 0 of the infection, and then treating for 3 days thereafter. So the drug's being exposed from sporozoite to early infection. And when we're doing radical cure mode, we're treating 4 days post-infection and allowing for the hypnozoites to be determined, and the Schizons will be a differentiated population. So the treatments are very different. It's more active in prophylactic mode because this is when it's targeting an earlier stage and the parasite's probably more vulnerable, and it also could be targeting the sporozoites upon entry. And when it's in radical cure mode, you have those populations that are more established and they're much harder to eliminate. So I don't think it might really reflect how to change the dosing. The radical cure treatment mode in our model would be more reflective of how you'd want to do your dosing for vivax.
Thank you.
They have a question from Victor for Alison. There was the antagonism between DHA and Tafenoquine observed only on B symptomology or also on B vivax.
So is the question, are the results similar between P cynomolgi and P vivax in vitro models?
Yes.
Yes, it is similar. So I didn't show any of the data today, but UGA has also conducted these studies as well with Dr. Steve Maher and Dennis Kyle, and their results are very similar to our results. And hopefully that'll be a paper that should be coming out soon.
Thanks, Alison.
Thanks.
If I don't know if there are any more questions from the participants. We don't have any more in the Q&A, but if you have a question and would like to raise your hand, now would be the moment. Otherwise, I'm going to wrap it up. Okay. Who has? Right. Well, I'm going to take silence as general appreciation of all the 3 talks and the responses. I'd like to thank everybody very much indeed, particularly all you who have attended at various times of day and night. Especially thanks to the panel, to the speakers, and also to the organizers of this webinar. So thank you very much indeed. And from here in Southeast Asia, good night.